All right, guys, happy Friday. Second week of summer core lecture series. I'd like to welcome Dr. Hina Dalal, one of our QI chief residents, who's going to be giving us a lecture on Heme emergencies. And Dr. Dalal is applying to Heme fellowship.
Facts, yes. Okay. All right, so let's go ahead and get started. Let's see. How do I go to the next slide?
Use this or the clicker will work too.
Oh yeah, let's do that.
It's like an ongoing problem.
What did you click on?
I just clicked the thing. So if you can go from here or
Oh,
you can
okay.
use the clicker.
Okay, I'll just do the arrows. Yeah. Okay. Can you play it for me?
Yeah.
So I don't mess
Oh
that up.
no, I think because it's not downloaded. No. Do I still have the other one?
Maybe. This is complicated.
This is complicated.
That's the second slide up there.
Well, anyway, welcome to hematology. What's your favorite blood cell? Macrophage?
Whoa, nobody messed with this guy.
Okay. My favorite is eosinophil for obvious reasons. Bill, what is your favorite? Red blood cell.
Why?
Well, it's empty inside and it does the same job every day until it's no longer useful to anybody. And I would describe my body type as a biconcave disc.
All right, so that's just a little intro. We're not talking about a lot of particular cells today, but that's okay. All right, let's see if this works. Okay. All right, so the outline for today, we're going to talk about neutropenic fever, spinal cord compression, hypercalcemia of malignancy, tumor lysis syndrome, and leukostasis. So mostly things that take you from sleeping to waking up. When you get pages about this overnight, during cross cover, when your senior's not around, etc. Uh-oh. Darn. Okay. All right, so let's start with neutropenic fever. So to start with neutropenic fever, you should define neutropenia and fever. So neutropenia is an ANC or absolute neutrophil count less than 500. And in order, you should definitely know how to calculate this. Most of the time you'll get your absolute number off of your differential, but if it's not like spelled out for you that this is an absolute neutrophil count, you want to take the absolute number of granulocytes, add it to the absolute number of bands, and multiply that by 100. So you don't ever want to report like a decimal point or anything like that. You actually want to say the number of cells. The other option is to take the granulocyte percentage and bands percentage, multiply that by your total WBC count, and then multiply all of that by 100. And then a fever is defined by a temperature over 100.4 that's sustained for 1 hour, or a temperature over 101, even if that happens just once. Oh gosh, okay. So this is very commonly seen with hematological malignancies and solid tumors. It's secondary to cytotoxic chemotherapy. And usually your WBC count will hit its nadir in within 7 to 14 days of receiving treatment. So generally the infectious causes, bacteria is more likely than viral. And then that's more common than fungal etiologies. It used to be that gram-negative rods were the most common source of infection, specifically Pseudomonas, but it's changed over the last several years. And it's now staph and strep that are the most common. Generally, you know, when the patient is anticipated being started on a cytotoxic chemotherapy regimen that's going to, and based on which disease they have, if there's an expectation that they're going to have prolonged neutropenia or at high risk for developing neutropenia, most primary hematologist oncologists will start them on prophylaxis medications as outpatient. And so that usually includes a fluoroquinolone. So you get pseudomonal coverage, an azole, and then like an antiviral such as acyclovir. So neutropenic fever is a medical emergency. So something really important for you guys to recognize and recognize it early. Antibiotics have to be started within 1 hour of presentation. And it's really important that you get a good history with a complete review of systems. So a really thorough physical exam is important. You want to make sure you're checking the oral cavity. You want to do a full skin exam. You're looking at lines, drains, catheters. You're looking at the perianal and rectal area for any abscesses, and you want to assess for abdominal pain. So a word on the rectal exam, it's visual inspection only. This is a one time in life where if you have a neutropenic patient that's for some reason having a GI bleed or anything, this is a one time you can, when the fellow asks, like GI fellow asks, did you do a rectal? You can proudly say no, and you'll be like right for not doing that. And the reason we do that is because cytotoxic chemotherapy damages the mucosal lining of the GI tract. And if you are going to be doing a digital exam, you can easily induce infection. And that's the same reason we don't give any suppositories or enemas or anything like that to neutropenic fever patients who are constipated as well. And then a word on typhlitis. How many of you guys know what typhlitis is? No? Some of the seniors, maybe? Okay. Anyways, essentially it is necrotic enterocolitis in the setting of neutropenic fever. So the classic triad, which you may not have all three, is neutropenia, fever, and right lower quadrant pain. That's because it's most common in the ileocecal junction. And you generally can see inflammation of the colon wall on imaging, and they can have distended bowels as well. There is concern at times, that the bowel can perf. Unfortunately, usually when a patient's neutropenic, it really kind of precludes them from surgery anyway. They're not going to be great candidates for that. So a lot of this is a supportive care. So bowel rest, fluids, treating the underlying infection if there is one spotted, et cetera. These patients though, if it does perf, you'll see a really nice, quick, fast lactate elevation and decompensation. It happens, I don't want to say a lot, but it does happen frequently in the bone marrow patients. So what you want to do immediately when you recognize a neutropenic fever is start empiric antibiotics with vancomycin and meropenem. And these can be tailored based on clinical response after some time. So, if you check the mercenaries, if culture results are starting to come back or any other imaging or testing you did, you can start de-escalating or narrowing if you're able to. But if they're persistently febrile for 3 to 4 days, things aren't getting better, you should really consider adding an antifungal for mold coverage. And if the fever resolves at any point and then they become febrile again, you really need to repeat the entire infectious workup. Generally, you want to continue antibiotics until your neutrophil count has recovered. And GCSF, or like Neupogen, Neulasta, which is a granulocyte colony stimulating factor, can help bring up your neutrophil and WBC count, but it's only indicated under certain conditions. And this isn't something that you guys would order by yourselves overnight or on cross cover. It would be a conversation with the attending. So next I want to talk about spinal cord compression. It presents as back pain. And if any patient that is presenting to you with an oncologic history and has new or changed back pain, this should really be on your differential. It's generally reproducible pain and presents with point tenderness. You'll also generally see a degree of motor weakness, sensory changes, autonomic dysfunction. Think of Cauda-Equina syndrome. And the back pain almost always precedes any neurologic injury. So the average time from initial symptoms to diagnosis is 3 months, which is unfortunate because this is one of the things you really want to recognize early. And one of the pearls that I learned from one of our attendings, Dr. Clark, who normally gives this lecture, is that the thoracic spine is the most common site that you can get cord compression, because that's where the spinal cord is the narrowest. So it ends up being diagnosed in 30% of all patients with disseminated cancer, but only 5% actually experience the dysfunction related to spinal cord compression. And most common malignancies is you want to think about bone mets. So breast cancer, lung cancer, prostate cancer, renal cell carcinoma, and melanoma. So this is just outlining here. This is like right in the middle of the thoracic spine, and you can clearly see that, it's affecting the cord. So this is a surgical emergency. Early recognition, like I said, is key. Once there's full paraplegia for over 48 hours, it's not reversible. And so you really need to do a good thorough history and neuro exam. And MRI is definitely the preferred modality for imaging because you can get the most detailed evaluation of neurovascular structures. But in the ED or something, they're likely going to order a CT scan. Other options that are like available but not as helpful are bone scan or plain films. Whichever imaging you decide to do, just make sure you're getting a thorough evaluation of the thoracic spine. And this is something that warrants a stat neurosurgery consult. Yes, it's okay to page them at 1 a.m. for this, but make sure you not just you're waiting on following up on the scan and you see that there's concern for compression, but make sure you've done a physical exam on these patients as well. And if neurosurgery ultimately says hey, this patient's probably not appropriate for surgery, these are the types of patients that get a stat radon consult. So again, it's okay to page them in the middle of the night for this because there's general consensus that yes, this is an emergency. And what you want to do after getting those people on board is start high dose steroids, IV dexamethasone, 10 milligrams once, and then 4 milligrams Q6 hours. This is eventually going to be tapered off, and radon or neurosurgery kind of help with determining when it's appropriate to start tapering. And then, of course, you want to add PPI for GI prophylaxis if they're going to be on steroids for quite some time. So just kind of similar realm of how we treat this is brain lesions. So again, this is another surgical emergency. You especially concerned when there's radiographic evidence of vasogenic edema. So again, this warrants a stat neurosurgery consult followed by radonc, again, high dose steroids. And it's the same malignancies that you're going to see this with. So here, there's just pointing out this right frontal lobe mass with vasogenic edema. There's effacement of the sulci and mediastinal shift. So next up is hypercalcemia of malignancy. And this is, I'm going the wrong way. So it occurs abruptly, can be really severe, and it's associated with a poor prognosis overall. Common malignancies that you can see this with: breast cancer, myeloma, renal cell carcinoma, lymphoma, and non-small cell lung cancer. There's 3 main mechanisms of the actual hypercalcemia that's taking place. So the most common one is the humoral hypercalcemia of malignancy. This makes up about 80% of cases. And this is when the tumor itself is secreting PTHRP, or parathyroid related protein, and that binds to PTH1 receptors and increases bone resorption and calcium resorption from the kidney. The second mechanism, which is a little less common, is makes about 20% of the situations with hypercalcemia, is local osteolytic hypercalcemia. So basically the tumor is now secreting cytokines and osteoclast activating factor, which increases osteolysis and increases skeletal absorption of the calcium. And then the third scenario, which is really rare and about less than 1% of overall cases of hypercalcemia of malignancy and mostly associated with lymphoma, is when you have secretion of calcitriol. So elevated vitamin D, and it increases intestinal and bone absorption of calcium. So signs and symptoms, I think we all know, like the bone stones, moans, psychiatric overtones. I like this one because it also includes thrones. I thought that was funny. And signs and symptoms, so malaise, anorexia, EKG changes, it can precipitate sudden death. GI symptoms are fairly common: nausea, abdominal pain, constipation, polyuria, renal stones, renal failure, and then mental status changes. Be sure to look out for that, as well as muscle weakness. So how do you diagnose this, and what's the workup? So you should have a high clinical suspicion overall based on your history and exam and the labs that you're getting, but you want to be sure that you're looking at the corrected calcium. So like someone in the room offer up how they look at corrected calcium. Chris.
Correct for 0.8 for every 0.8 for the calcium for every one below where you are. So
Yeah, that was actually perfect. So for every drop in albumin by 1, so for every drop in albumin by 1 from a normal of 4, you're going to multiply that by 0.08 and add it to your total calcium. And you will definitely want to check an ionized calcium to send off PTHRP, PTH, vitamin D levels, just to be sure that we're not missing any other reasons for there to be hypercalcemia in the first place. And you should expect your PTH to be low, PTHRP to be elevated, and usually the vitamin D levels will end up being low or low normal. So overall management. So mild hypercalcemia, less than 12. You're going to try to encourage oral intake if they can tolerate it. You want to make sure you're stopping any medications that would be contributing to higher calcium. So thiazides, any calcium or vitamin D supplements. And then for moderate hypercalcemia, levels 12 to 14, you want to start aggressive IV hydration. You want to use normal saline. We're talking about rates like at least 200 cc's an hour. You may even have to be more aggressive than that. And once they're euvolemic, then you can consider loop diuretics. So Lasix will help bring down that calcium, but you definitely don't want to do that until they've been adequately hydrated. And then, of course, for severe hypercalcemia, you want to be thinking about bisphosphonates. So these take several days to work. You're not going to see that change in your calcium for a few days. One that we use commonly here is pamidronate. So it's going to be a 60 to 90 milligram one-time dose. And then I just wanted to mention calcitonin because it comes up a lot when we're on inpatient service. And it's important to note that, well, I put all the dollar signs there because it's expensive, but it's also just a temporizing agent. So there's really not a lot of great indications for it. Like one example that I could think of when we used it on service is a patient who had hypercalcemia of malignancy and pretty bad heart failure, which we couldn't do super aggressive IV hydration for. And we really needed to, and it was severe hypercalcemia. We needed to get that calcium down rapidly. So we started the bisphosphonate, but while we were waiting to have that take its effect, we also did a dose of calcitonin. And you want to make sure it's IV calcitonin and not nasal calcitonin. The nasal calcitonin like won't do anything at all for this situation. About like 12 to 14 hours or so. Yeah. And then just a word on denosumab or Xgeva. So this is a monoclonal antibody. It's approved by the FDA for hypercalcemia of malignancy specifically. That's refractory to bisphosphonates. We also use this a lot in people who need bisphosphonate therapy, but who have underlying renal dysfunction. Again, it's going to take some time to see that it's actually working. Okay, next up is tumor lysis syndrome. So this is when tumor cells release their intracellular contents, and it's due to rapid cell turnover. It's more common in acute leukemias, CML and blast crisis, and aggressive lymphomas such as Burkitt's or immunoblastic lymphoma. It's not that it's like you can never see it with solid tumors, but it's more rare in that situation. And you really want to be able to recognize who your high-risk patients would be for this to happen. So anyone who has a disease with tumors that have a high proliferative rate, which are going to be like very sensitive to cytotoxic therapy, anyone who has large tumor burden, so bulky nodes or large masses, high serum LDH, or anyone who has some degree of renal insufficiency at baseline. Overall, tumor lysis syndrome has a pretty high mortality rate, so it's something that you really want to be cautious of, and something as the interns you're really going to be doing a lot of work for, because it does require a lot of frequent lab checks and follow-ups and so on. So this is a nice diagram from the British Journal of Hematology. It kind of just reiterates a little bit of what I said, that solid tumors in general are low risk for disease. And then hematological malignancies in general are also low risk, especially if you're looking at CML in the chronic phase. This doesn't apply to CML that's in the accelerated phase or blast phase. So that's something to keep in mind. And on the flip side of that, acute leukemias is where you're really going to be seeing a lot of this. So if you look at all the way at the right, Burkitt's lymphoma, you're automatically high risk disease just at baseline, just by the nature of that disease. But looking at ALL and AML, the couple of things that are going to put you in a higher risk or intermediate risk category is if you have an LDH that's greater than 2 times the upper limit of normal, or if you have an elevated white blood cell count. So those are the things that are going to make you high risk. And so this diagram from New England Journal of Medicine basically demonstrates like what happens when cells are lysed and what are the byproducts that are accumulating in the blood. And it's important to know that TLS is laboratory TLS and then clinical TLS. So when we're talking about laboratory TLS, they give you some cutoffs of what electrolyte levels you should be looking at. So uric acid of 8, potassium greater than 6, phosphate greater than 4.5, or calcium less than 7. But the other caveat to that is that it could also just be a 25% increase from baseline. So if you have someone who went from potassium, like baseline potassium's like stone cold, like right around 3.5, if it goes up all of a sudden to 4.5, that still may be considered a normal potassium, but that's more than 25% increase from baseline. So something to keep track of. So you could have all of these things, and that would basically qualify you for laboratory TLS. But clinical TLS is when essentially you have renal dysfunction from it, you're developing cardiac arrhythmias, seizures, or other mental status changes. That's when you can say that you actually have clinical TLS. So this little schematic is from CP Solvers. I don't know how many of you guys follow that, but they're like really big with med ed. This is something they put on Twitter like last month, and it's just a little schematic again showing like what are the contents in the cell that are released to the extracellular fluid, especially when the cells lyse, and all the different things that are result because of that. And one of the mnemonics I like to remember, and you just want to know this cold because your attendings will ask you this on rounds. I think of puke calcium. So phosphate, uric acid, potassium are all E elevated, and then calcium's low because you puked it out. So that's how you can remember which electrolytes are going in which direction. So taking a further look into some of these electrolyte derangements and how we manage them. So first talking about hyperphosphatemia, which results in hypocalcemia. You can see calcium phosphate crystallization. You'll have prolonged QTC that can lead to arrhythmias, muscle cramps, tetany, hyperreflexia, and seizures. Try to use phosphbinders if you can, calcium gluconate or calcium chloride, and then, if necessary, dialysis. And I think hyperkalemia, we all kind of know the biggest thing we're worried about is cardiac arrhythmias. And management, you want to try to deplete total body potassium. So Kayexalate, Lasix, again, dialysis is an option. You can temporize things by shifting potassium intracellularly with insulin and dextrose or an albuterol neb. And then you want to stabilize the cardiac membrane as well with calcium gluconate. And then the main one that a lot of people worry about with tumor lysis syndrome is hyperuricemia. So it's interesting because it can be pretty asymptomatic on its own. It can cause some urate nephropathy, but that's rare. But the biggest thing is that it prevents AKIs from recovering, and it can actually precipitate worsening renal failure. So for this, again, you want to do aggressive hydration. A lot of patients are already put on prophylactic allopurinol, and you want to make sure you're resuming their home dose when they're admitted, or you can start it while they're here admitted. Now, rasburicase is one of those things that we do use for TLS for severe hyperuricemia. You can't just place an order for it. You have to call Dr. Smith. He's a nice guy. He won't most of the time yell at you over the phone, but you want to call him to get approval. And you usually only need a single dose. 3 to 6 milligrams is usually sufficient. And it is expensive. So that's why we need to get approval to make sure it's being used for the right indication. But interestingly enough, they did a study kind of outlined on the right here And it was published in Blood in 2012. And they compared allopurinol to rasburicase. And ultimately what it showed is that, yes, rasburicase is, more expensive by dose, but ultimately it led to lower length of stay, both ICU and non-ICU. And ultimately ends up costing the hospital less than using allopurinol. But that being said, like I said, there's specific indications for this, and it's not something that we can order freely. So something that'll be like a discussion with your senior or your fellow. So overall mainstay treatment, tumor lysis syndrome, fluids, electrolyte management. And as an intern on cross cover or anything like that, if you get a page about a patient who's in TLS, the nurse says their urine output is dropping off, or like their labs are ordered Q4, but those aren't being drawn Q4. Like those are the situations where you're going to have to spend some time with the nurse, make sure things are being ordered, just so you can keep up with the electrolyte derangements and make sure they're being corrected. And then you always want to have these patients on telemetry. Okay. So next up, we will talk about leukostasis, which does come up fairly often as inpatient. So hyperleukocytosis is when your white blood cell count is over 50,000. But leukostasis is are the symptomatic manifestations of when you have a really high WBC count. And this is, again, a medical emergency, and it's generally, you won't get the symptomatic manifestations unless you have increased blasts. So a white blood cell count alone is not going to do it unless on the differential you see that there's an increased blasts. So for this, you want to think of your leukemia. So AML more so than ALL or or more so than CML or CLL, that should say. This is really similar to hyperviscosity syndrome, which can be due to like increase in other cell lines or proteins. So what we see in Waldenstrom's or myeloma, thrombocytosis, or PV. And the reason you see it with the blast is because the blasts are large and sticky, and they basically clog up the capillaries and cause sluggish blood flow. So yeah, like I said, there's sludging of circulating blasts that causes mechanical obstruction of small vessels and causes malperfusion. And the blasts themselves release cytokines that allow them to adhere to the endothelium easily. So things you should worry about with leukostasis and when you're evaluating a patient at bedside. So you want to be thinking about altered mental status, any focal neurologic deficits, blurry vision, tinnitus that's new onset. They could be having chest pain due to decreased myocardial perfusion. They can have dyspnea, hypoxemia, and actually can develop respiratory failure if this isn't treated. And then AKI, and then TLS itself is associated with leukostasis. And in terms of other vascular things, you want to think about DIC, venous or arterial thromboses, or even priapism. So management for leukostasis, again, is pretty common theme with a lot of these emergencies, but it's definitely hydration. You want to be able to increase the plasma volume with IV normal saline. And ultimately, you want to treat the elevated WBC. So you want to do cytoreduction. So that could include treating the underlying leukemia. So if it's AML, you're going to be thinking about 7+3 induction. A lot of times overnight, what the fellow will do is recommend starting hydroxyurea. And it's for people who may not necessarily need immediate induction, or sometimes when you don't have a diagnosis just yet, but you know there's an elevated white blood cell count that needs to come down, they can offer that. And then the other option is leukapheresis. And that is very rarely done here. And there's very specific indications for that too. And again, that's going to be a conversation with the team. You know, the patient's going to need a special type of line and all that kind of stuff. So just something to think about. And then again, manage TLS as we talked about before, and then supportive care for DIC. The big thing I want you guys to be aware about is being really judicious about transfusions. So when these patients come in with a white count of 150,000, they're also going to have platelets that are like 15K maybe, or a hemoglobin of 6.5. And we're so used to transfusing to a hemoglobin of 7 or platelets greater than X for, bleeding or whatever. But If you transfuse, there's a chance that you're going to make their blood more viscous. So you don't want to do this without talking to your fellow. I would probably even skip the senior, just go straight to the fellow for this, because it can be really scary. Of course, if it's an active GI bleed or hemorrhage, or then you're gonna be more cautious about, you're gonna probably give blood anyway, but definitely a risk versus benefits situation before just throwing blood products at them. All right, so just want to do some practice cases again. Things that can change when you're sleeping versus when you have to wake up. So first scenario, a 78-year-old man is evaluated in the ED for a 1-week history of weakness, fatigue, nausea, and anorexia. Medical history is remarkable for recurrent squamous cell carcinoma of the lung treated with surgery and chemotherapy. On exam, temperature is 99, blood pressure is 90/60, heart rate is 100, and respiratory rate is 20. Confusion, skin tinting, and bitemporal wasting are noted. Laboratory studies show a BUN of 30, calcium of 13.5, creatinine of 1.9, and a phosphorus of 2.4. What is the next best step for treatment? Who wants to take a guess? Yep, great. So why did you think C? Okay, good. Yeah. So I think the main thing was the difference between C and D. So like I said, Lasix is going to bring that calcium down for you, but you don't want to do that until the patient's been adequately hydrated. So yeah, definitely C is the right answer. All right, scenario 2, a 65-year-old man is hospitalized for treatment of stage 3B diffuse large B-cell lymphoma. He's to begin chemotherapy with R-CHOP. And on exam, vital signs are normal. He has enlarged firm lymph nodes that are palpable in the left supraclavicular and left axillary areas. The remainder of the exam is normal. His hematocrit is 34, LDH is 190, uric acid is 7.5, and creatinine is 1.1. CT scan shows no bulky tumor masses. He started on normal saline. And which of the following do you think we should also add prior to starting chemotherapy? Any guesses? Gabe, what do you think? Good. Yes. So why would we do allopurinol? Exactly. Yeah. So, he's not taking any prophylactic meds. So before jumping to something like respiricase, you would definitely want to start that. And it says he's to begin chemotherapy, so he hasn't even started it yet. So you want to get ahead of it, is essentially what they're trying to get at. All right, case 3. A 58-year-old man is evaluated in the ED for a 3-week history of worsening pain in the mid-back and a 2-day history of increasing leg weakness that has made ambulation difficult. He has metastatic prostate cancer treated with leuprolide. On exam, vital signs are normal. Muscle strength testing shows 4 out of 5 weakness in the hip flexors. Reflexes are 3+ in both legs. An MRI of the thoracic spine shows a contrast enhancing mass originating in the T8 vertebral body with invasion in the epidural space that's causing moderate compression. After administration of high dose steroids, which of the following is the most appropriate next step in management? What do we think? Someone say C? Yeah, good. So you want to basically consult neurosurgery for decompressive surgery. It's always, you always want to do neurosurgery before radonc. And a lot of times you want to hear back from neurosurgery before you even get radonc on board. So just something to keep in mind for sequence of events. All right, case 4, a 27-year-old male is admitted overnight as an outside hospital transfer, which is common here. Needing higher level of care due to suspected CML, BCR-ABL testing is pending. He complains of fatigue, diffuse bone pain, and scattered ecchymoses and petechiae. Labs are obtained which demonstrate a white blood cell count of 140,000, 98% blasts, hemoglobin 6.8, platelets 18,000, an INR of 1.6, and a PTT of 45. He denies any chest pain, shortness of breath, headache, or blurry vision. He is currently not on any medications, and the IV fluids that were started at the outside hospital have been continued as normal saline at 100 cc's an hour. What is the next best step in management? Any takers? What did you say? D, yeah, okay, great. Do you want to explain your thought process behind that a little bit?
First, you want to increase the viscosity by transfusing of this.
Perfect, yep.
Platelets with blood.
Mhm. Exactly, yeah. So that's definitely like pretty much sums it up. The one thing I would say is that, you know, it wouldn't be completely wrong to do imatinib. It is cytoreductive treatment, but the thought process in this is that it's suspected CML and you're still waiting on BCR-ABL testing to come back. So these are just like little caveats in the stems, but again, in real life, you would do the hydroxyurea first, and probably something that any attending or fellow would feel comfortable with doing overnight. Hydroxyurea acts pretty quickly and brings on the white blood cell count pretty fast. And even if you overshoot that a little too much, it's okay because once you discontinue the medication, the white blood cell count bounce backs pretty quickly. So just something to keep in mind. All right, we just have a couple more. 24-year-old man is evaluated in the hospital for new onset chills and Rigers. The patient was recently diagnosed with diffuse large B-cell lymphoma and received his first cycle of multi-agent chemotherapy 10 days ago. He doesn't have any indwelling lines. On exam, his temperature is 102, blood pressure is 90/40, heart rate 130, and respiratory rate is 24. There's no evidence of rash or mucositis. Chest is clear to auscultation. The abdomen is non-tender. There's no evidence of a perianal abscess. Labs show hemoglobin of 11.5, leukocyte count of 800 with 10% neutrophils and 90% lymphocytes and a platelet count of 100,000. Chest radiograph is normal. Blood and urine cultures are pending. Which of the following is the most appropriate immediate next step in treatment? So which antibiotics do we want? B? So yeah. So why B? Yeah. So you want to, one of the things you want to remember is pseudomonal coverage. So you'll get that from your Zosyn and you'll get that from marrow. But specifically at our institution for neutropenic fever, based on susceptibilities and resistance and stuff, we definitely do meropenem first. And you want to be sure to include vanc initially. You can definitely peel that off later, but to start with, you definitely want to do vanc and marrow. D is incorrect because you don't want to add on fungal coverage right off the bat. That's only if the patient's persistently febrile for several days after being on vanc and marrow. What is the neutrophil count for this, or sorry, the ANC for the absolute neutrophil count for this patient? Or like what math would you do to? Yeah, so just 10% of the total WBCs, which is 800. If they had mentioned any bands, you would take that into consideration as well. All right, so last one. So a 36-year-old woman is hospitalized with a 2-week history of gradually worsening dyspnea on exertion, facial swelling, and a sensation of head fullness. She has had fatigue, night sweats, and a 10-pound weight loss over the past 2 months. Her medical history is unremarkable. She takes no medications. On exam, her vitals are normal. She is not in respiratory distress and has no stridor. She has facial and neck edema, and her face appears flushed. There's no lymphadenopathy. Cardiac, lung, and abdominal exams are all normal. CT scan shows an 8.5 centimeter right-sided mediastinal mass with compression of her SVC. There is no evidence of thrombosis. There are no other areas of lymphadenopathy and no lung masses. Which of the following is the most appropriate next step in management? This is kind of a curveball because we didn't really talk about this, but I did want to throw something about this in there. So any thoughts on what would be the next best step? I heard C. D, okay. Any other thoughts? Someone said A. Okay, so we're basically getting at all of them. So this is actually a pretty tough question. And this is one of the mixed up questions on this topic. So what they're trying to get at here, they kind of already told you the diagnosis is superior vena cava syndrome. I wanted to bring this up because it's not considered a medical emergency anymore for hem-onc emergencies. It's urgent, but not emergent. That being said, what they're trying to get at here is that you have someone who's come in with a newly found lung mass, which happens a lot. You'll probably accept this patient to gen med because they don't have a diagnosis yet, so they won't go to oncology. But what you want to think about is the fact that they don't have a tissue diagnosis yet. So that kind of takes away a couple of your options, one being dexamethasone, because if you give steroids, yes, it'll help relieve symptoms, but now you could have changed the histologic findings, and you definitely don't want to do that before you get a tissue sample. Same thing with urgent radiation therapy. So they're not going to radiate a lesion, even if it's for like palliation purposes, until there's a tissue diagnosis. So we really can't do either of those two. The percutaneous intravascular stent placement is super interesting, and it's definitely like more commonly seen done now, both clinically and it's kind of all over the literature. But basically that is for if a person is in acute respiratory distress. So if they're having stridor, any concern for possible impending like airway compromise, or anything like that, which they kind of spell out for you in this stem that she has no stridor, she doesn't have any respiratory distress or any tachypnea. So you want to start with doing a mediastinoscopy, and the reason for this is to get a tissue sample. The other details they told you in this case to say that she couldn't get a tissue sample any other way is the fact that they said no other areas of lymphadenopathy, that like you can't go after a node anywhere, or any other lung masses. So that's kind of why they're getting at mediastinoscopy. So just briefly on SVC syndrome, like I said, no longer considered a medical emergency. Most commonly seen with lung cancer, so both small cell and non-small cell lung cancer, and then your non-Hodgkin's lymphomas. There are non-malignant causes that can cause, SVC-like syndrome. So infection, fibrosis from like indwelling lines or pacemaker leads or like other things like that. And then of course, if there's a thrombus, like I said, mainstay of management is you want to be able to diagnose the malignancy and then treat it. And then of course, relief of symptoms based on if they're needed. And if you have a diagnosis, you are definitely going to think about the stent, steroids, or RT. We are just getting to the end. This is a pro tip for intern year. Can you guys read that? It's good advice. And I will take any questions. I don't know. I don't know. I don't know if it'll be palm or ENT. It may be palm. I don't know. I'm not sure, to be honest. I have never had to have a patient who needed that because there's generally another site that you can get a diagnosis from. Yeah. You probably, it depends on the timing of getting that stent in place. It seems to be that the stent is now the more recommended thing as what you would do first prior to even giving steroids. If they're really severe symptoms, it would be something that you would talk to your fellow or attending about, because if there's concern that they're not going to be able to get the tissue sample from anywhere else, then they may want to hold off on the steroids. But if they feel pretty confident that they can get a tissue sample from somewhere else, or if they're suspecting a disease where the steroids may not affect the histological chain, like the tissue, then they may say, okay, to give steroids, but definitely the stent is probably the more common way to go now. Yeah. Any other questions? Okay, thanks, guys. Oh, sorry. I'll let you go ahead and do that.